Welcome, everyone. Somebody tell me if they can't hear me speaking, but my name is John Willie. I'm on the board of directors for the American Society for Stereotactic and Functional Neurosurgery. And I want to welcome you all to our webinar tonight on DBS targeting. I want to thank Sharona, who's been organizing this webinar series, and thank her for the invitation and helping to put this together. And tonight I want to introduce, we have two guests, John Rolston, who is Associate Professor of Neurosurgery at Mass General Brigham Harvard Medical School. He's a stereotactic and functional neurosurgeon. He's an NIH-funded researcher. He's certainly a leader in our field. He's a frequent speaker at courses and conferences nationally and internationally, and we look forward to hearing from him tonight on the basics of doing DBS. And then we also have joining us tonight as a discussant, Michael Okun. He's a professor of neurology and director of the Norman Fixel Institute at the University of Florida. He's a movement disorder neurologist who dabbles in all sorts of indications for neuromodulation. He's also an NIH-funded investigator, and he's sort of the brains behind the annual DBS think tank, which gathers luminaries in neuromodulation annually to exchange data and ideas. So with that, hope everyone can hear me. I don't see any messages saying we're having any issues. So with that, I'll turn it over to John and have him take it away. Thanks, John.
Great. Thank you for the invitation to talk and to present on some very basics of DBS targeting specifically. So this is a very introductory kind of process of this. So forgive me if this is beneath anyone that's listening, but we can always get into more details if that's helpful for people in the question part of it. So here are some disclosures, some consulting I've done for various companies, one of them which is involved in DBS. Directly, or actually several of them that are involved in DBS, either making the devices or making the targeting. So I think the main indication for DBS that I'll be speaking about tonight is for Parkinson's disease. And so I'll start by just taking a few minutes to kind of get us oriented to why we need to do this, which can help us understand why we have the tools we do. So some of the initial treatments or initial therapies surgically for Parkinson's involved things like cortical extirpation. And this is a skull x-ray right here from one of Busey's patients in the 1930s, where they did a cortical resection to actually treat the symptoms of Parkinson's. And you can see those WEC clips that are left behind after the craniotomy, which was done with the jiggly saw back then, which was effective at controlling the tremor and some of the symptoms, but obviously had pretty severe side effects. So there was this constant search for new ways to treat this disease that weren't as morbid as that. There was also something like multiple subpial transections, which was done here in Boston by Earl Walker and James White. And that also could help these symptoms, but again, left a lot of high morbidity. So eventually people started looking at other parts of the pyramidal motor system and actually started lesioning the cerebral peduncles as a more efficient way to get the same sort of control of the motor cardinal symptoms of Parkinson's. And it was during one of these that accidentally Irving Cooper, who was a neurosurgeon in New York, was ligating some blood vessels that were in his way to the peduncle and accidentally got the anterior choroidal artery. Really helped the symptoms for the patient serendipitously. And when he went back to revisit why this worked, even though he hadn't been able to complete the operation he wanted to, he was able to see that this was actually supplying blood to the globus pallidus in this particular patient, so that the part of the basal ganglia. So people started experimenting more with the extrapyramidal system. Myers did this with multiple different areas. And when we really got to this idea that maybe these deep areas are really the most effective for treating Parkinson's with fewer of those side effects, but we needed to do that less invasively. Unlike the motor cortex, where you can do a surgery and directly see the motor cortex, or the cerebral peduncle, where you can do a surgery and directly visualize that, it's really hard to do an open surgery and directly see the internal capsule or the thalamus or the globus pallidus. So we needed to find a way to get to these areas less invasively, deeper, with a high degree of accuracy. More information about the circuitry involved in Parkinson's came later from people like Mahlon DeLong, who was at Emory, the late Mahlon DeLong, and sort of understanding why this particular therapy of the pallidotomy might have been so useful, as well as understanding other similar nodes within the network, like the subthalamic nucleus. So here, this is just to orient people that there's this normal circuitry we presumed at this time. It's actually probably much more complicated than this. But when there's a dysregulation of dopamine, some of these areas become overactive, in particular, the subthalamic nucleus and globus pallidus internus. And because these are overactive, they tend to inhibit the thalamus, and that leads to this more bradykinetic phenotype we see with Parkinson's. One way to restore this, at least initially we were thinking, was to get rid of these overactive areas. Either the pallidum, so if you do a pallidotomy, you get rid of that over-inhibitory drive on the thalamus, releasing that hold, the brake on the thalamus, or the subthalamic nucleus can release that its brake on the, or its activation, overactivation of the globus pallidus. So there's these two critical nodes that were found to be really important in this, and lesioning was the main way we tried to treat that until DBS came along. So this is a slide from Mike Okun, and whenever I'm trying to drop a lot of Mike Okun joints into this one because they're all great. So when I have the opportunity, I'll do that. But this one, this is a great figure that shows the basics of the DBS system that we all love and has been FDA approved since 1997. There's an electrode that goes to these deep areas. In this case, either the subthalamic nucleus or the globus pallidus, which are the main ones we use for Parkinson's, but also the thalamus for tremor. There's that electrode in the head, and there's a lead extender that connects that electrode, which is a little more robust to turning in the neck, down into the pulse generator in the chest. So 3 pieces. But we still want to get these wires down to these deep areas. So taking a step back to say why this is so effective or what the evidence of this is, we have great data, which is not something we have a lot of in neurosurgery for many of the procedures we do, but we have really good randomized controlled data supporting the efficacy of DBS for Parkinson's. In several journals like New England Journal, JAMA, showing that it can help stabilize motor fluctuations, provide more on time, and improve quality of life. We also know that these effects are durable, lasting not just the first year you implant it, but 5 years, 10 years later. When you analyze these people again after that and check them, the DBS is still having a pretty fair, good benefit. So it's not just an acute treatment of their symptoms, but something that persists over time. Despite all that, it's heavily underutilized. So only about 1 in 10 patients that are good candidates are actually being referred. And half of these referrals are self-referrals, not through the community physicians that are taking care of them or that are managing them. A lot of this is fear of surgery, so things like hemorrhage or stroke or anxiety of the operation, despite these risks being very low and manageable. So one of our jobs as functional neurosurgeons is to try to make these procedures safer, make them less anxiety-provoking, to get more patients interested in this and less fearful of it so that we can treat more people and get this life-changing benefit into their hands and into their lives. So we have these 2 targets that are in this circuit that we believe are overactive, and we have evidence for lesioning that is effective. And now we want to know which one we should target with our DBS. So this question, again, touched upon by Nolan Williams, along with Mike Okun here in this paper from about over a decade ago, which is still excellent. Initially, there was some really good evidence, some class 2 to 4 evidence that STN might be the better target for treating Parkinson's over GPI. So there were studies by Crack, there was the PD study group in the early 2000s, and that maybe the GPI might wear off a little more quickly in terms of efficacy over the lifetime of its use. So more people were implanting STN predominantly compared to GPI. But then some more careful studies went to actually directly compare this. One of the first was by the OHSU group, which looked at a couple dozen patients with DBS and either the GPI or STN and didn't really see much difference in the UPDRS score, but did see a difference in medication dosage. Then the NIH COMPARE trial came out with about 50 patients, no difference in mood or cognition, and no difference in UPDRS, although it wasn't really what it was designed to check, but still kind of suggesting that maybe these are just as good or equally as good. A bigger study, the VA co-op study with almost 300 patients, was published in 2010. And there, again, no difference in the UPDRS-3. STN had a better reduction in levodopa requirements, so a better medication reduction than GPI, and some worse signals for depression or visual motor processing speed, although they were doing a lot of analyses, a lot of these secondary analyses, and weren't doing much correction for multiple comparisons. Another trial, fourth one, NSTAPS, looked at over 100 patients with bilateral DBS, no change in mood or cognition between the two groups, and no change in the UPDRS scores between the two groups. Maybe activity, or the ALDS score maybe was a little better for the STN. But overall, it seems to be a pretty fair draw between the two targets. We have guidelines, organizational guidelines from the CNS reviewing all this evidence that were most recently updated in 2017, trying to adjudicate between these two targets as which one might be better. They asked 7 particular questions. First was, is there a winner for UPDRS-3 scores? And there's a tie according to this, so either one seems to be equally as good, and there's class 1 evidence for that. The reduction in medications, STN appears to be more superior than GPI for that, although GPI might still get a 10% or 15% reduction in medications. For dyskinesia specifically, it depends. So if the person is having their dyskinesias because or at the peak dose of their medication, perhaps STN might be a better target because you can reduce the medications more rapidly or more aggressively. If they seem to be not related to the medications, then maybe GPI, which probably has some sort of direct anti-dyskinetic effect, might be a better target in that case. Although this is where it really takes a lot of discussion with the patient to really kind of get the phenomenology of their particular dyskinesias timed well. And it can sometimes be a little unclear. For quality of life, no real difference we can tell. Both seem to be good. Cognition, memory, working speed. For this guidelines, they're suggesting that GPI would be superior to that, as well as for mood. And then adverse events, no real difference between the two. There might be some suspicion that the microvasculature of one of the two targets might be more prone to hemorrhages, but we haven't seen that borne out in any reliable data. When should DBS be offered? Earlier is usually the answer. So there was one clinical trial that was pivotal in this and actually changing the FDA indications, which was the early STIM trial in 2013. And this looked at several hundred patients and looked at whether they did it earlier or later in a delayed fashion, and the people that got it earlier did better. So the minimum of the 4-year duration is what's in the FDA approval right now. There's some different trials that are about to be started by David Charles at Vanderbilt to look at ultra-early DBS as possibly disease-modifying treatment, but that's still clinical trial level, so we don't have the definitive evidence for that either. So now we know that these two targets are great. We might prefer GPI for some patients. We might prefer STN for others. How do we get our electrodes there as neurosurgeons? So in general, when we navigate with anything, there's a few different ways we can do that. And you'll kind of think about this in terms of your own practices. You can either directly visualize something. So when you're taking out certain meningiomas, for instance, you can take off the skull and you can see it. And then you can take that out. Or if you see a calf mal or something that you can look at with your own eyeballs, that's direct visualization. This might be improving with things like augmented reality, where we can actually use that to buttress our normal eyesight. There's landmark-based navigation, where you look at something that is a known object external to where you're going, but then you can use that to infer the actual location of your target. So something like when you place an external ventricular drain, you use known landmarks like the nasion, the midpupillary line, the external auditory meatus to find your trajectory. That's using external landmarks to find something that you cannot see yourself. But that relies on a certain amount of invariance upon those things that are related to those landmarks, which might not be the case. Everyone has different brains internally. When you do rodent surgery, for instance, this is actually more reliable because they're so inbred that there's not a lot of variability in the brain compared to where Bregma is, for instance. But for humans, there is a lot of variability. Coordinate-based navigation, which is really the bread and butter of functional neurosurgery, tries to put a coordinate space, an XYZ type coordinate space, into or overlaid on a person's brain, and then use those coordinates to identify targets and entry points. And that's the language we mostly use. And it's made easier by the fact that things like MRIs and CT scans are in a coordinate space. So the voxels are identified by that same sort of XYZ nomenclature. A last way to define things is sensor-based. And by this, I mean using something to kind of tell you by intrinsic signals in the body or the structure that you're navigating through where you are. So if you can't necessarily rely on the coordinate-based navigation, you can use this sensor to see where you are in a different way. So kind of like using a metal detector at the beach. There's this film still here from The Terminal Man, which is a great Michael Crichton book and the movie from a while ago. But they're in that from the 70s, they're actually using this real-time navigation to tell that they're near a blood vessel and then backing off and then trying to find a target to treat epilepsy in a responsive neurostimulator back then. So now we're doing that in real life. But for this, for DBS in particular, the way we mostly do this is with microelectrode recording. So here you're looking at intrinsic physiological signals that you're mapping as you go down to tell you, to infer where you are in the brain, to give you a different signal that might give you more information than you're going to get just from the MRI or CT scan you got beforehand. So for stereotactic surgery, you need to know where this target is, so where the STN is, and you need to find a good way to get there. The main way we do that right now is using that coordinate-based system and then using a frame typically. Some frame or some other way of navigating like a robot or the ClearPoint system that relies on a lot of these same principles. So there's steps that you'd take whenever you're doing these surgeries. And these are going to be broken down pretty basically just to help you appreciate why we do the things we do. But you first want to target. So you identify your target on something like an MRI or a CT scan. And now you want to navigate in the real actual world to get to that target. And that's not on an MRI scan, that is in the operating room. So in order to link those two, you need to do some sort of registration, some way to link that map you have from beforehand to the person sitting in front of you. And that's that registration step that we all do. So whenever we're targeting some more general principles, you can do this targeting either directly. So you can actually see what you want to find. So you can use an F-Gator scan, for instance, which we'll talk more, and see the target in the GPI you want to hit. Or you can use indirect targeting, which was much more popular until more recently for deep brain stimulation. Indirect targeting means that you might not be able to see directly the target you want to hit. It's still the case probably for VIM of the thalamus, where it's hard to discern where that is with the current MRI sequences we have. So you find something you can see very reliably, and usually that's the anterior and posterior commissures. The reason we still use those and rely so heavily on those is because they were easy to identify in pneumoencephalography or ventriculography. So when you do a lateral skull film with someone with a pneumoencephalography, you can see those contours in the ventricles, identify the AC and PC, and you can use that to map where you're going to be in the real world from that point on. Before they started using PC, they actually would use things like the pineal calcification, which you can also see on an X-ray pretty well. So if you go to the really old papers, you might see that instead of the PC. This is all opposed to direct targeting, where again, you can just see what you want to go and you put your coordinate right there. And that's preferred because there's so much variability in people's anatomy. When you can directly see it in target, you should do that. So AC-PC space, anterior commissure, posterior commissure. We do this to find that shared coordinate space and then to get a kind of rough idea of where we want to be with our initial stab at the target before refining that with direct targeting. We still look at the AC-PC as we've done for many decades now. I usually use the inner borders of these, the interior borders, to kind of replicate what they would do on the pneumoencephalography or the ventriculography, rather than trying to get the midpoint of the body of those two structures. Typical AC-PC distance is about 25 millimeters, so somewhere in that ballpark. Another important coordinate is the mid-commissural point or the intercommissural point. So you might see that as MCP or ICP, depending on the papers. But that's that halfway point between the anterior and posterior commissures. Some standard quote-unquote indirect coordinates that people use to identify structures are shown here. There are standard ones for the VIM, for the GPI, the STN. These are ranges depending on which papers you look at. For the centromedian nucleus, which is becoming more popular for epilepsy, there's a kind of standard one that's used a lot, which is 10 millimeters lateral to PC. Tends to be a little off when you actually analyze that. It comes from the Schaltenbrand and Warren Atlas, and it's probably more reliable if you're a little more medial than that one. But you can use these indirect coordinates to get an idea for a ballpark where you should be, but you probably shouldn't rely on those to actually do the targeting. You should instead do direct targeting. So I was trained by Paul Larson and Phil Starr, and so I think one of the best ways to show this is from their chapter in the Yeoman's textbook, which has these really beautiful illustrations showing what it would look like at ACPC plane. So after you've reformatted everything, when you find that medial border of the GPI, when you identify that, and here it is on an F gator on the right here, you can see that medial border. And again, we're at ACPC plane, so you can see the anterior commissure and the posterior commissure right there. You find that border, the medial border of the globus pallidus internus, you divide it into thirds, and then you go up for that most posterior third, and then you go in about 3 millimeters. And that gives you a really good entry point into the GPI. Then you want to extend that down until you get close to the optic area. And you'll see that on the F gator, as you go lower, you'll see that dark band of white matter coming back from the optic chiasm to kind of know that's probably too deep once you get there. But that's a good way to identify where you want to go. And often it ends up that this point is probably right at the border of GPE and GPI. And there are some people that think that the GPI might even be more important for stimulation. But this is the way I do my direct targeting for GPI. For STN, I do the same way that Phil Starr does and Paul Larson. So you go to this line of Bijani, which is finding the red nucleus about 4 millimeters inferior to ACPC plane. And once you identify that anterior border on a T2 weighted MRI, you go lateral until you see the medial border of the STN. And then you go about 2 millimeters into it. If you can see the lateral border of the STN, which tends to be much more indistinct, if you can see it really well, you can just do the midpoint of the STN. So you're smack in the middle of it, medial lateral. Often the width of the STN is about 4 millimeters, so it ends up being 2 millimeters, which is a pretty good rule of thumb. That's why we stick with that one. But that method is a good way to find it. If you can't see it at -4 very distinctly, you can sometimes go up a millimeter or down a millimeter, -3, -5, and find it more distinctly there and pick it. And that ends up being a good target as well. There are more advanced sequences that are being experimented with. So for STN, typically we use T2, and that's still what I do day to day. But quantum susceptibility mapping is another way to really bring out with a lot of contrast the red nucleus in the STN, which you can see here in this paper from JNS a few years ago. It also really works well for GPI too. So you can see in the same one, not only the STN and red nucleus, but also the globus pallidus externus and internus. For GPI, F gator is one of the kind of best sequences for that. But many of the inversion recovery family of sequences, so an MP2 RAGE, not an MP RAGE, but an MP2 RAGE, white matter null, or again, QSM can also find that the border between GPE, GPI, and then GPI in the internal capsule. 7 Tesla imaging is becoming more available. It has better acquisitions or better image quality for comparable acquisition times than the 3T. These are from my center, some 7T images. They're not perfect, and there's a lot more distortion and susceptibility artifacts because of the strength of these magnets. So the actual targeting accuracy is not quite as proven as it would be for the 3T, although when I've tried to go back and forth, I don't see a meaningful difference between those. But for instance, this T2 star image here on the top, you can see the red nucleus really easily, and the border of the STN is a lot more distinct than it was on the 3T. And then these are some pictures of the GPI, and you can see even some of the individual fibers that are crossing through the capsule right there. So really amazing, great image quality with this. So now you've done your targeting, and now you need to navigate. So again, you have this map that you've created in an MRI space on a computer somewhere, but that's not going to get you very far unless you know how to use that in the real world with the patient who's asleep in front of you or awake in front of you. So to do that, you need to co-register. So you have a map. To co-register that to the real world, you need to find something in the real world that is on that map. And then you can start measuring things from there. So in this sort of image on the side, you can look at a New York City map, and you might be able to find an intersection or the Statue of Liberty or something that's in the real world, and that's fiducial. So you need some sort of fiducial. When you're using a stereotactic frame, that often comes in these localizer boxes that you put on that have these radio opaque N shapes on the sides of them. And when you look at that, no matter where you do your CT through that, you can then determine how far you are from the base ring. This N bar, which was made by a med student at the University of Utah many years ago, uses this simple trigonometry to say that if I know in the real world how far these two uprights on this N should be, and I see them, and they're not at that exact distance, then I know there's some orientation in the slice, and I can compute that with trigonometry. And then if you find, when you're looking at the space between these two, one of the uprights and one of the diagonals, as they gets closer and closer, you know exactly how much superior you are from the base ring. So you can calculate the position of any slice in the CT space based upon where that frame is sitting on the person's head, no matter how you mount it. So this became a way to translate a CT scan into that map from the Lexel frame or the CRW frame or any of the other frames we have. Then you also need to fuse that to the MRI if you're not doing a direct targeting with an MRI. So if you're not doing the Lexel mapping with the MRI. So you fuse that. Image software does this automatically for us now, introduces a little bit of error. But it's a way to get that link from an MRI to a CT scan, which has these fiducials, which you can see in the real world, to that patient that you're operating on. So now you have this target, you have it in a stereotactic space. So you have this MRI coordinates. You can put that now into Lexel coordinates or next frame adjustments or clear point adjustments. And that is an XYZ target. And then the trajectory you define by kind of how you get there. You should always think about how that affects your ultimate DBS electrode orientation, because it's not just a point that you're targeting, you're actually targeting a span for this electrode. So 7.5 millimeters or 10.5 millimeters, you need to understand where that's going to sit in this structure. And sometimes if you have really big ventricles, you might be coming more laterally, so you need to maybe adjust your target based upon that. A lot of sources of error when you're doing this. The MRI has its own sources of error, 7T being worse than 3T, which is worse than 1.5T, but the image quality is better on the higher one, so there's a bit of give and take there. The frame can have some sort of error intrinsically to it, depending on how it was manufactured, the last time it was calibrated. They're supposed to be calibrated much more frequently than most places calibrate them. When you try to place the frame, historically it was better to place it along this cantho-meatal line, or the line of Frankfurt, which approximates the ACPC line. With imaging nowadays, you probably can get away with not doing that, but it's a good rule of thumb. If you can get it that orientation, it might just make it a little bit easier for you. If you over tighten the frame, you can start to distort it. Same thing with some of the clear point frames, for instance. If you over tighten those, you can distort them. You have to assemble it correctly. So there are many times that people have assembled it upside down or backwards and put it on and realized that you're not going to get the right answer for it. And then you have to put that fiducial box, if you're using one for something like the Lexel, really seated properly. If it's up a little bit, it's going to give you a wrong answer because it's assuming that it's flush with that frame. And if it's not, it's going to give you a wrong answer for exactly what coordinates you want to get to. The accuracy for any of these fiducial methods is variable. When you use bone fiducials, so actually CTing something that's screwed into the bone, it's around 1 millimeter-ish. When you use those skin stickers, like the little donut things we use for MRIs, it's more 4-ish millimeters. Surface matching, which is the bread and butter for tumor surgery, where you use the contour of the forehead attached to a CT scan or MRI as your fiducial and match that. About 3-5 millimeter error out there, which is fine for most of the stuff we're going to do for tumors, but not good enough usually for DBS. A frame has 1, 2, 3 millimeters of error. Starfix maybe the same. Next frame about the same, and ClearPoint has probably less than a millimeter because it's more built into the MRI system, so you're getting rid of some of the registration steps there. Last part I'll touch on is microelectrode recording. So with microelectrode recording, now you have your target, but there's always going to be some errors, like we just talked about, and the brain can shift a little bit once you make a burr hole. So there can be some pneumocephalus, which pushes the deep structures around a little. So in order to refine this, you can do microelectrode recording to get an idea for what structure you might be in at any given time. The microelectrode tip itself is about the size of a cell soma, so 30, 40 microns. And it's capable of recording from single cells as well as populations of cells. And so what I mean by that is you can imagine an electrode, a microelectrode, a high impedance electrode, like sitting in Fenway Park, which is my local stadium here. So you can be next to somebody, really close to them, and you can talk to them and hear what they're saying. That's like the single cell being really close to the tip of this microelectrode. Or you can hear the cheers or boos of the crowd, these loud roars, which are the population of these, thousands of people that are further away from you, indistinct, but still giving you some sort of meaningful sense of how the game is going. So that's two different sources of information, kind of the roar of the crowd or the people right next to you. And that's what you're getting with the microelectrode, the LFP background, as well as the single cells that you're isolating. When you're recording through the STN, you usually start 10, 15 millimeters above, and you generally go from areas of lower activity to higher activity as you get to your target. So when you're going through the thalamus, it's kind of lower amplitude, less quick. When you go to the zone incerta, you might not see much at all, or maybe some spiking. STN, you see a couple changes. One is that the background goes way up because it's that sort of population around the electrode is more active. And then the number of spikes you're identifying also goes up. And then it changes character in the SNR. So it's a little bit more regular, higher pitch in the background goes down a little bit. If you actually quantify something like the RMS noise of these signals, which is just how much stuff is going on, you see that really well when you get into STN. And that's a reflection of that whooshing you hear in the background when you're listening, when you're making audible these electrical recordings. Another way to show the same thing, so white matter, because there's no neurons there, there's just the axons, are not very easy to pick up with a microelectrode unless you're really close to a node of Ranvier. Thalamus tends to be more sparse activity, zone incerta, usually not much. But then the STN, you get a lot of activity, as well as if you look at this background, kind of the thickness of this dark band in the middle, it's much bigger than you get in the ZI or the thalamus or even the SNR. And that's a reflection of the density of the cells and the activity of the cells. GPI has a similar profile. Again, you want to see more activity when you're in your target. GPE, when you're recording from that, will have both bursters and pausers. So bursters have these bursts of activity, and then areas where there's not much, and then these pausers will be kind of the inverse of that. So more regular activity, then a big pause. So you'll see those two classes of cells in GPE. When you get to GPI, it becomes more regular, a little more active. Occasionally, you'll get border cells. These border cells can be either at the border between GPE and GPI, or the internal laminar border between GPI, the external segment, and GPI, the internal segment, also called GPIE and GPII. So the border cell can be either before you get to GPI or right in the middle of it. And again, you see that same sort of higher frequency, more reliable firing on either side of that border if you get it. Then once you get to the optic tract, you get, it's more white matter, so you get really kind of thin, tinny spikes that are lower amplitude if you get them. You can also use those local field potentials and look for some sort of consistent changes in the background. A popular one to look at is something like beta that seems to be correlated with being in a good run of the STN. This is commercially available in some of the software you get now, but it's a more advanced way to look at these things. But a good microelectrode recording will get you most of what you need without the LFP. Test stimulation. So not only can you put this electrode and map it, but you can also stimulate from it electrically to kind of simulate what you're going to get with the DBS electrode. So this is one of my favorite slides from one of my favorite people, Paul Larson, showing an axial view of the STN and kind of what you expect and how you might change your location of electrode if you find something you weren't expecting. So if you're right in the STN, you might get overactivity of the STN, which would drive that, a sort of over accomplishment of your goal, which was to get rid of that overdrive of the STN. And so when you have too much dopamine, you get dyskinesias, kind of like if you're having too much of a good thing here, you might get dyskinesias directly with the STN stim too. So that can be a sign that you're actually in an okay place. If you're too far posterior, you can get paresthesias. Too far lateral, you get capsular side effects. And you can also get diplopia from some of the cranial nerve nuclei. The GPI is a little easier in the sense that you really only get side effects when you're in the internal capsule. You can get visual side effects if you're too deep, but not much. You're not going to find much to tell you that you're too lateral in this case. The other thing that you're going to look for in all this is how this testing can affect the symptoms of Parkinson's or tremor if you're doing essential tremor. And that can be something you can assess right there in the OR. Things like dystonia, which we haven't talked much about, are a little harder to check, but you can still at least do the test to verify that you're not in one of these side effect inducing areas. So with that, that's kind of a whirlwind tour of the very basics of how I started thinking about targeting these things. Way more you can get into detail for all the microelectrode mapping, stimulation, targeting, how we actually do the surgeries, whether robotic, asleep, awake. But I'm sure that'll be discussed in many more of these sessions to come. So thanks everyone for bearing with me, and happy to answer any questions or talk amongst the group.
Thank you so much, John. So yeah, we're open to questions if you all want to start sending them in. While we're waiting for some questions, let me just ask John, but also get Mike to perhaps weigh in. With this broad overview of sort of the basics of how you do things, recognizing there's many, many different ways to do things, I'm curious how you, John, and you, Mike, prefer to do it and why.
So you mean in the sense of like, so when I do my DBS like tomorrow, what am I going to do? So I typically do my Parkinson's DBS with a sleep and intraoperative MRI because we have good reliability of our outcomes with that. We're pretty good at targeting. When I started my career, I would ask every patient whether they wanted it awake with microelectrode recording or asleep, and 100% of them said asleep. And so after about 3 years, I just did everything asleep at that point. And I felt it in my hands anyway that the outcomes were comparable, and so I felt comfortable doing that. That's not advocating for that particular method. I think that anyway, you can get great results, and a lot of it depends on the center you're at and what they're comfortable with. There's a lot to be said for microelectrode recording and refining, especially the vertical extent of the vertical placement of the electrode, which can be really critical. And getting that extra information can change maybe where you put that second or third contact that I don't get with the asleep method, which would be better if we had that ability. So that's how I mostly do it. Occasionally, I'll also do it with a robot if someone has an MRI contraindication, like a cardiac pacemaker that we can't do. And I'll do that often asleep with microelectrode recording, just because we do so few awake ones, and I don't have a neurology colleague like Mike here to help me out in those cases.
Mike, how about you?
Yeah, so well, first, thanks, Sharona, for the invitation for organizing. John, great tour de force talk, and John. So if you're looking for an answer, just say John. Somebody will answer it for you on this talk. But the first thing I would just say is, I think one of the fundamental shortcomings that we all have is setting up ways to quality assure that what we're doing is actually what we think we're accomplishing. And so I think no matter how you do it, and I think everybody can get to from point A to point B in a lot of different ways. And you can do that in a lot of diseases, whether you're treating them medically or surgically. And of course, Parkinson being one of those ones where there's so many different ways to be successful in managing someone even without surgery. And so, I think that as a neurologist, one thing I would say to the group of neurosurgeons that's here tonight is don't be so sure that you've always got the best outcomes. And the best thing you can do is to actually set up a system where you can quality assure that you are, putting the leads where you want to, and you're getting the outcomes that you want to get. The way that we do it, Kelly Foote and I have been at it, for like 23 years now at UF. And so, you get good at your system. And so I have a slide I show on ASSFN each year, and, because everybody always asks, what's the best, what's the newest, whatever. And my answer is none of it. I mean, it's if you get really good, just like John said, if you get really good, really confident, you get your results, where you want them, and you have quality assurance to be sure you're getting those results, that's the right way to do it. How do we do it? Frame-based CT MRI fusion, microelectrode recording for Parkinson, essential tremor, and even thalamic cases as well. We just did one of each today. I just got out of the operating room. So thanks, Kelly Foote, for finishing in time so I could be with you all tonight. And then we have a quality assurance system where every single person, our neurologists actually are there and do the recordings and also help with the targeting. And then we send out an email to our entire group. We've been doing this for many years. That has a three-dimensional picture of the outcomes, where the lead is. We share it with patients, we share it with each other, and then we also look at the thresholds for benefits and side effects and follow along. And we use that's like a continuous discussion as to where do we need to be, and it will start to tilt your targets this way or that way. Trajectories change things, and so that you can keep not only improving your outcomes, but you can inform the surgical teams, and the surgical teams will inform the neurology teams on the ground. Okay, you're overcorrecting. Now we're overcorrecting, across. And that's, I think, one of the reasons why, and good surgeons get better the more procedures that they do, but the more feedback you provide, I think, is really useful. I think ClearPoint works. I think sleep works. I think awake works. I think you can put people asleep with a frame. I mean, you can do this a million different ways, just as long as you have the right quality assurance.
Yeah, let me just add to that. You might have a system, point of all this is to have many different ways to do things so that you can check, because on any given day, one of your ways might not be working. Maybe your imaging is not great, or the neurophysiology isn't great, or the patient can't tolerate being awake to do awake testing. So I think the point of this is not that there's just one way to do it. It is nice to learn one way and it works for you, but often you have to solve problems that aren't simple. And so I think it's useful to be able to learn multiple different methods so you can solve problems different ways on any given day for different patients. I've been in two different systems where things don't always work. So sometimes you have to solve problems in ways that might not be the way you typically do it. I taught my neurologists how to do microelectrode recording of the thalamus recently because they don't do it for thalamus, and yet we had to do a thalamotomy with a radio frequency probe. So we got to do microelectrode recording on thalamus because I knew how to do it from memory, but my WashU team doesn't really have experience doing that. So it's nice to know all the different ways to do things so that even if it's only once or twice a year where you need something you don't routinely use, you can still do that. So we got a few questions here. So somebody's asking, how do you think the CNS guidelines for STN versus GPI targeting may change with updated data on directional stimulation and or adaptive stimulation?
Yeah, I don't think for choosing between the targets, I'm not sure they would change because I don't know of any new evidence that has really significantly changed our ability to differentiate in terms of UPDRS outcomes between the two targets, or really change our outlook on the side effects between the two. Directional leads, it's nice to have directional leads, but it is not a crutch for targeting. So you shouldn't say that now that I have directional leads, I don't need to worry about the accuracy. You still need to get a really well-placed lead. And adaptive stim, I don't, we'll have to see how that evolves once it is in our clinical hands more day to day than it is right now. And I guess that might change the benefits of one particular target if it has the ability to turn that on. But again, I'm not sure as far as the ultimate improvement of the UPDRS. I'm not sure if that's going to change our guidelines quite yet. Maybe Mike has better thoughts on that or different thoughts.
I think you nailed it. I would just add that a lot of these guidelines, I've been on a lot of guidelines committees, and now I try to get off of guidelines committees because so, guidelines are kind of made to be broken in the real world. And in the real world, as you're dealing with these folks, you have to think through not only acutely what's sitting there, the easy stuff. And we have, healthcare, we try to do things so fast now and just have to slow down, tap the brakes and see, actually ask ourselves, what does the person look like now? What do you think they're going to look like in 5 or 10 years? We don't do that enough. The guidelines kind of hurt us in that way because they try to, start to steer you, one way or the other. Oh, I just do this because of the guidelines. But let's take, for example, a pretty common situation where somebody isn't tolerating very much levodopa without getting very dyskinetic. the guidelines don't really help you there, but you know long term if you could suppress the dyskinesia and use more levodopa, you're going to need that for a lot of symptoms, neuropsychiatric symptoms. It's going to be better long term. You may even end up having to go back to a different target because you chose one over the other. So that's just one example of many that I think is the reason why when they pay us and ask us to be part of an interdisciplinary team, we kind of weigh in across these things. And I think, it's kind of like Harvard and Yale. We got one guy from Harvard, maybe Harvard and WashU, two great universities. It's not like, you have bad choices, like you're going to make a bad choice if you go to one or the other. But, I think trying to think through how you could help, the person, if they're not on a randomized trial, how you can help them the best in the long term, I think is important. And I think that's one of the reasons why guidelines committees are nice, but they fall short in the real world.
Dario Anglot's had his hand up. Dario, do you have a question?
Thanks. Yeah. So thanks very much to you, John, and also to John and Mike for their presentations. These are great. And I this like awake versus asleep movement disorder DBS is, the age-old debate at this time. And at our center, we do it vast majority awake, and we find with our awake mapping, we move more than 70% from our intended target, either tract or depth. But every single study that has looked at this has shown, basically no difference. And so I know Florida has done probably the most in the country, and John has done an incredible amount now. But it's like, I guess my question is, I can't say, oh, my question is awake versus asleep. But my question is, how do you make a decision clinically when you just don't have clear differences in the in your data and the research? How do you make your decision for your program?
Yeah, I mean, so I think, it's a great question. And I mean, the way that I look at it is, take a step back, for a minute and just say, look, you can get there a lot of different ways, right? And so a lot of people want to crusade and fight over one thing being better than another, but it's just a technique, a way to journey to a particular Cartesian space, and so there's a lot of different ways to get there. So I think us beating each other up, like about, like this one's better than that one or whatever, isn't that useful. I think where we run into trouble is when, we have what Richard Feynman and, several famous scientists have said, where we start to see the things that we want to see. We design the studies to show what we want them to show. We were talking about this in the operating room today about a study one of the fellows brought up, and how, that you can design the study to show what you want. I intended to put the lead here, it is here, and okay, like, good, close the book, we're done, right? And so, but it's kind of more complicated than that, if you do it right. And the equipoise question of, of being able to randomize, like once you have your method and go head to head against a different method, it's harder on methods than it is on targets or on, particular treatments when you're randomizing people. So it's very difficult to do. And, I will just say that I think that the sample sizes, we don't do things like with cancer trials are done in thousands of people to get large effect sizes. We just can't do that in device studies. So, it's unlikely you're going to get to those effect sizes to be able to show the differences. But I do firmly believe if you don't put a quality assurance system in, no matter what you do, and your leads are coming out and you just tell yourself, look, they're great, they're where I put it, and I'm, and you see some of this in the literature, then that's what you're going to see, and that's what you're going to believe. But if it was your family member and what I know, and everybody knows on this, call session tonight as a closed club, we probably would want, millimeters matter in brain space, and we probably want to make sure we're getting to the right spot. And, and John, Rolston, I gotta say, well, John R. said, in his talk, that, there are, 4 different main methods in order to be able to navigate. And so employing as many of those as possible, if you're good at it, because remember, a fool with a tool is still a fool. So I think we just have to get rid of the kind of the dogma and the self-righteousness, of like, oh, it's good and I can show it's as good. It's not really a comparison, and we're really kind of, in my view, we're looking at it wrong, and we should more Dead Poet Society and stand up on the table and look at it from a different point of view. So I think you're just going to continue to see that go on, because you just can't get to the effect size you need to do the study that you want to do. And I think we need to shift the dialogue to being a more productive dialogue, which is how can we improve the outcome for every person, regardless of what technique we do.
Yeah, I'm just going to comment on that and then ask the next question. But sometimes in the emerging literature on a sleep direct targeting, where it's only sleep, it's only direct targeting, the outcome that matters is how the patient's doing, not whether or not it looks like it's in the STN or in the GPI or whatever, because this turns into this closed loop discussion of, if the patient's having an issue, well, the surgeon just looks and says, well, it's where I wanted to put it. It's there. So therefore this can't be fixed and we can't do any better. So that's not the result we're looking for. The result we're looking for is how the patient's doing. So again, using all the tools available to make sure the patient gets the best possible outcome. And if we can do that asleep with direct targeting most of the time, great. But sometimes we have to fall back on some of our other tools.
Yeah. I will just add to that parenthetically that, one of the things that we've had going on since 2005 is the DBS troubleshooting clinic here, which has got to be one of the busiest in the world. And we see several people every week with leads, and we see good leads. We see leads at work. We see in between. I mean, so you learn a lot. I mean, we just have learned so much from that experience. I do think that we have to, as a field, come to terms with the fact that if you can't get a certain amount of volume, we know this from lesions and we know this from DBS, like if you can't get enough volume in the right area, you're not going to get full benefit. And I think when you average out these studies, if the leads are, out, it may look good, particularly when you're doing bilateral and one lead can cover for another lead. So we have to be really careful, you put the lead in and you can't get it above 1 milliamp or 1.5 milliamps. You're unlikely to get to a volume where you're going to have long-term sustained benefit. And we continue to just kind of say, well, that's where we want it and it should work, and, fix it. And it's done, but it doesn't really work. So I think we just have to be a little more honest on these things and take a lot of care. And when we see people for troubleshooting, we spend like 2 days with them. It's not like it's not an easy process to do, but you learn so much, and half of those people you can help. But who has 2 full days, in the real world to work these people up and try to figure it out? And it's a racket of missions, right? So
it's a humbling business. So another question is, if you are doing a sleep or under anesthetic DBS, what are the considerations if you still want to do MER? So do you guys have any insights in that? So what sort of anesthetic protocols to use?
So I'll just start by saying all the way back to Emory days, and John spent some time in faculty, or actually John W. spent some time in faculty at Emory, right? All the way back to Emory days with Malin and Jerry and everything. We would record, and when we held a cell, by the way, when we got a cell, we would drive Roy the Kid crazy, because we got a cell, we would hold it as long as we could. It was like the monkey, like when we got a cell on the monkey, we would just, that's a good cell, we got to record it for as long as we can. And Roy'd be like, we can't do this in the operating room. And we would try to hold these cells, and then the anesthesiologist, we'd hold them so long, would sometimes give Versed or give a, thing. And so we would watch to see, the MER disappear and everything. And I think we fooled ourselves a little bit for a while, with thinking we couldn't see enough of the MER with a lot of these anesthetics. And certainly some of the acute benzos were knocking them out. And then we learned over time that you can actually, it may change the firing rate for sure. It may change what you look, but a lot of times you can actually record through some of these, dysfunctions. And then some of the very sick dystonic kids don't have a lot in their pallidum and they're not firing a lot. So you fool yourself. It's not actually really the fact that they're asleep. And then we started to do these kids awake and realized that they weren't there. So I think we've kind of learned over time. Our bias was that it destroyed microelectrode recording, and we've learned over time we can probably record through it in a lot of these cases, and then also lighten people up to test them for capsule and things like that, to try to get a better sense of where the lead is. I think from a physiology and a research standpoint, it does affect firing patterns and rates and things. You have to be really careful with that data. And a lot of the data that's in the literature is frankly just, particularly the early data, is just it's so gross. It's like, how fast did this cell fire? I mean, it's kind of garbage. It depends on, some of these cells were held for 6 seconds, or 2 seconds, and they just keep counting. And so I think we've learned we can actually record through a lot, and then a lot of people are using DEX and things like that these days. So I don't know, John, you're smarter than me, John R.
No, not no, but we use remifentanil and sevoflurane when we do our asleep microelectrode recording, and so we still get good recordings. You can still very easily see STN and SNR and the borders there, and GPI. It is slower than it would be if they were awake without anesthetics. But the differential activity is still pretty stark, and you still see things like beta, maybe sometimes a lower frequency if you're looking at the LFPs. So I still think it's a useful adjunct, and it might, when I do that, similar to Dario, I usually change my depth by maybe 1 millimeter or so, based upon that. When I do that with the ROSA is how I typically do these asleep microelectrode recording ones. It'd be nice one day to have microelectrode recording in an MRI to see if that changes things further, or to have a vertical span of the electrode where these kind of the exact depth might not be as critical. We have some wiggle room right now with the contacts we have, the span, but maybe if we had more span, more directional, maybe you can take a little bit of that urgency off to get the perfect vertical, and then really more worry about the XY location of your lead.
John, since you brought up robots, you had shown the general accuracy that's been published for some of these other devices, but you didn't happen to mention the ROSA. You just
So I think it depends on which of those registration methods you use for the ROSA. So you can use skull fiducials for the ROSA, or the Renishaw, or any of the other surgical robots, not to pick on ROSA.
Yeah.
So you can use skull fiducials, you can use surface registration, you can use any other thing that's compatible with it, and they will carry over their accuracies into that robot's accuracy. So I typically use skull fiducials in the form of Lexel pins to do that, which I think is superior accuracy to surface matching. I would not personally trust surface matching to do a DBS case. I think it's too crude to get you accurate where you need to be.
I think Zach Levine has a question.
Yeah, so a couple of things. Number one, thanks so much for the presentation. I've been doing DBS for about 25 years, and I graduated out of frame-based surgery into frameless surgery many years ago. And I use a StarFix platform. And I really see this as a physiologic operation, not an anatomic operation. And so I use MER for everything. And you've touched on this a little bit, but so my feeling is the presentation really indicated that there is a need for accuracy, but when it comes to your final result, and Mike, you know this as well, aren't we more concerned about the physiology? Because the cells, although they're important, it may be the white matter that we want to stimulate. And so shouldn't we be more concerned about the MER and the physiology in these operations rather than the MRI anatomy?
So I think they're highly correlated. So I think the microelectrode recording that I do is often trying to confirm where the boundaries of these anatomical structures are that I'm seeing on the MRI. So I'm looking for like the dorsal border of the STN, and I'm hoping that it matches with where I think it's going to enter based upon the MRI. And when it doesn't, there's a problem. But often it ends up being confirmatory for what I would expect to see with that tract. What could be different is the amount of beta differentially in different parts of the subthalamic nucleus. And what the electrode recording doesn't get you is where the rubber hits the road, which is the person's physiological response to test stimulation. So there
Right.
you can get, yeah, that's different. And there if you're getting the good result, it kind of doesn't matter what you got on your MRI or what single cells you recorded or not. If you have a good result, that should speak volumes to it. It can be sometimes deceptive based upon some sort of edema you might have, or if you have a microlesion effect, maybe you can't get a good response. They're verify that you're getting that good response you hope to get. There can be some fluid which can shunt currents. So intraoperatively, it cannot always be exactly what you see post-operatively, but it tends to be pretty good, reliable. I guess, Mike, how often when you're doing the testing, do you how would you weight those internally, like the microelectrode mapping versus some test stim that you might get after it? If they were ever conflicted, what would you go for?
Well, first, nice to see you or hear you online, Zach, and I appreciate your question. And I was thinking about it as John was answering, and I think part of what you're getting at is it's really a neural network dysfunction. And so when you talk about it being a physiological target, you are trying to alter, the physiology within that neural network, right? And it's sort of a little bit of a humbling game, to get it as close to wherever that node is. And a lot of times it's white matter, and we're learning it's white matter and white matter tracks, and we haven't talked about this, but that may be where the field goes, away from gray matter targets, and is already sort of navigating away to figure out where on these nodes, on these superhighways, we can maximize benefits, minimize side effects, and light that network up. But we actually just don't know, Zach, yet, like even when we see a super responder, like what in drug trials we would call a super responder, we don't tend to use that term in surgery. Maybe we should. And you look at the super responders and you wonder, did we hit that, like the right spot? And then how do you know if you just didn't hit, in another person? And then the phenotypes are so different in diseases like Parkinson. And so I think it becomes really difficult. I actually think that it's the conglomerates of factors that help us in the operating room to decide where to put leads. And then when we replace a lead in a troubleshooting case, our own, by the way, like don't think that we're high and mighty and righteous. We replace our own leads too, and we miss too. So everybody misses. If you don't miss, by the way, that's a problem. So like if you're not missing at all and you're not thing, then I would just say anybody listening here, you're probably fooling yourself a little more than a little bit. And so obviously I love the MER targets, love to get 3 dimensions of the MER targets. And in the day, 20 years ago, we would do 6-8 recordings. We now know that's probably not good for the brain to poke it that many times, and also OR time, like we'd had to speed up because we couldn't sit on these cells for 5-6 minutes, 10 minutes. If we could hold a cell for 10 minutes, we would do it and bring it back to the lab and consternate on it. And it was a lot of fun. You can't do that. It's not good for outcomes. And so, coming down to a couple of tracks, maybe simultaneously, maybe in sequence, and trying to get a 3-dimensional picture, use the imaging, use the direct targeting more than the indirect targeting. And then trajectory is underappreciated. I think, every time I go in the OR now, even in the last case I walked in and I said, "Hey, Kelly, we're very vertical here, like on this, and this is going to change everything, and it was a great discussion for the fellows, as we do case by case, and sometimes they have to go, because we've stopped, we don't take veins anymore. We try to stay out of venous infarction, increasing risk for those types of things. And so the trajectory helps us. The macro stem we've been learning, on the and fundamentally from our former fellows who leave our program and come back and say, "Hey, old man, why do you not use more of the macro stem off of the DBS lead?" So we've been trying to actually do our own data from quality assurance to see what correlates versus the tablet versus what system we use, whether it's Frigidaire or Alpha Omega or whatever, and then figure out how we could use that to help us to make decisions. And the trajectory is super important. We try to get the we get the optic pathways in multiple ways on the GPI cases, and boundaries are important. And I agree with John. Even under anesthesia, except in these very severe dystonia cases, we usually can get enough MER, and it is very helpful. And then just one last thing: 2 cases today where the lateral passes were longer, in the lateral pass, right next to the capsule, and 2 cases today in the MER. And there's an old paper that Jerry Vitek and I wrote many years ago where we just showed how you could do this, how you could put, and it makes perfect sense. I mean, it's not like we were super smart or anything. We just drew a picture of how you could put the DBS lead in long runs of STN or GPI and be right up next to something that you don't want to be right up next to. And a lot of times the first pass ends up there, even with the best direct targeting. And so I think that's where MER can help you, and to sort these things out, even the best of surgeons. So I don't know. Did that answer your question? I feel like I'm meandering now.
No, I think you did, Mike, and John. This has been great. I also want to echo that directional leads do not make bad surgeons good surgeons. They compensate for patient anatomy, as you just said, Mike. Sometimes we really suffer trajectory a lot, and I talk about DBS as a vector-driven operation, and you have to maximize your penetration through the target, whether it's GPI, BIM, or STN, avoiding vital structures or things that will make the anatomy more difficult on the other side, like a ventricle. So thank you so much. I will shut up. You guys have been great. This has been a wonderful opportunity, and thanks for allowing me to observe and listen.
I'm going to have to close this here in just a minute because we're at time, but I do want to advertise that this is only part 1 of this series, so of how to optimize DBS targeting. Next time we'll talk about some of the more advanced tools, advanced imaging, research methodologies. There were questions about these things, and we just couldn't get to them all. There was one final good question that I think it touched on some of the things we had here, and I just want to close on this, which is somebody was asking, a lot of the people who are doing really good quality of sleep DBS, they didn't start that way. They had, a decade or more of experience learning it the hard way and learning all these tools. And so when somebody's coming out and they may have only learned it the shortcut way, they may not feel like they're going to be comfortable getting those types of outcomes. So again, I'll let John and Mike close on this, but learning all these different ways of doing things, it does help us understand these targets, all of these methods, the imaging, the physiology. These are surrogates and correlates of the outcome we want to achieve. They are not the endpoint in and of themselves. And so they're just tools to get us there, and we sometimes need multiple tools.
Yeah, and so you have to be able to adapt your methodology as times change. So, and when I was trained, I never had a surgical robot, so I had to teach myself how to use that and be comfortable with it and get better at it. And I do far more sleep DBS than I initially did, but having that feedback loop for the outcome is critical to know what you're doing well and what you aren't. So. Constantly being open and communicating with the people that you are, the patients long-term, the neurologists who are programming them, looking carefully at your electrode reconstructions is all really critical. I'm lucky that Andy Horn does all my electrode recons, and so if I miss, it's really obvious very quickly. And then having my neurologist tell me like what the off meds on DBS scores were. Whether they wanted, maybe they're using one of the ring contacts when they would have preferred a directional contact. All that helps me understand. And I've actually changed my practice significantly based on all that. Even compensating for things like the usual overshoot I do for MRI based, it actually changed based upon the MRIs we have here versus at the University of Utah by a millimeter. But you don't get that unless you're constantly getting feedback. And you absolutely critical, like Mike said, to adapt and change yourself to improve and get the best outcomes you can for these people.
Yeah, I would just
Okay,
add, in closing, I think all the questions are great. We could go on forever, and this is, could evolve into a nice bar discussion. I would just say quality assurance, like just don't be so sure. I mean, I've learned so much by seeing all these troubleshooting cases, and just don't be so sure. Don't trust one modality. Don't point to the image and say, I meant to put it here. Like these are things. I've been around to various operating rooms around the world and seen people in debating and trouble, and so I've seen that a number of times, and I think we just don't take yourself so seriously, and the other thing I would tell you, and being like very invested in patient advocacy as a medical director for Foundation for 20 years, is if you're actually honest with people, like they appreciate it. So a lot of times we feel like, oh my gosh, and even early in my career, oh man, I missed her. Like we made that lesion too big when we were making a lot of lesions, and and you just, if you communicate well and you just share with them what the journey's actually better for everybody, and you can fix them faster, or they'll work with you faster, like along the way, and your team will actually move in a much more positive, manner. So I think it's, just really important to be humble, but just realize that you don't have to like hide, like anything. You just tell people we're just continuously trying to make things better. And I can show you slide after slide after slide of Kelly Foot's complications. He often says, hey man, you like making me famous by showing my complications. I said, exactly. But that's the point. The point is, we can all get better, and that's what it's all about. So yeah.
Well, on that note, I want to thank everyone for joining us tonight, and please do join us again for our next session. Sharona, do you know what the date is for that?
Yeah, really. Thanks so much to our speakers. This was such a fantastic talk, and thanks, John, for moderating. The next session is part 2 of this series. This was intended to be kind of basics and overview, and the next session is advanced tools, advanced imaging, and sort of along the line of research methodologies to continue to advance targeting. And so we will take some of the questions we got today and shift them over to the next section to make sure that they are addressed. That will happen on March 12th, and it'll be from 5 to 6 p.m. Pacific. So same time as this was. Thanks again, everybody, for joining us.